So, even though it looks very, very simple, sometimes interpretation of chest radiographs is the most difficult among the radiographs. So, let's see, I've tried to simplify it, and within 15 minutes, let's see how much I can cover. Because our body has, especially in the thoracic region, different densities of the tissue. So, what is a chest ray? It is a shadow because of the differential absorption of radiation when we perform the X-ray. And finally, when the image is formed, it has different shades of gray as well as black and white. So how does it happen? Because of the hierarchies of densities and absorption of X-rays from least dense to most dense extends from gas, air in the lungs up to bone, the most dense tissue of body, and sometimes metallic objects like foreign bodies. So before interpreting the chest radiographs, we have to keep certain things in mind, like structured evaluation. We have to be consistent every time. Before reading it, we make sure that it is for the intended patient and the date is correct, as well as if we have previous radiographs, it becomes helpful for comparison. And we have to see that it is optimally obtained. Technically, the chest radiograph is also good. And finally, we should interpret the findings. So there are 4 major positions for frontal radiographs. It can be posterior anterior or anteroposterior, depending on the availability as well as the condition of the patient, and lateral views, and in sometimes decubitus. There are some additional views also in certain circumstances, like oblique views, apical views. We perform when it is required. So before interpreting, we make sure that the radiograph is technically adequate. Look for the penetration. So it has to be adequately penetrated, and the spine should not be visible from the carina downwards or not. It should become hazy. Otherwise, if it is, if it is over penetrated, we miss the findings. If it is under penetrated, we may say that there may be false positive findings. And the radiograph should be taken in adequate inspiration. Otherwise, we may not be able to see all the lung fields. Look at in this radiograph, because it was poorly taken, poor inspiration. It looks like there is soft tissue densities here. But when again it is taken on adequate inspiration, we can see all the normal lung fields. As far as possible, there should be no rotation on the chest radiographs. The lateral views always help us in supplementing the findings of the posterior anterior views. It can be left lateral or right lateral, depending on which side the pathology is on the frontal radiographs. We need frontal radiographs for the finding of pathology and lateral radiographs for location of the pathologies. So we know that the lung has 3 lobes on the right side and 2 lobes on the left side. So when we try to put the lobes on the 2D images of the radiographs, this is the region occupied by the right upper lobe superior to the minor fissure, and the lateral radiographs comes to our rescue because it shows the exact demarcation of the upper lobe. This horizontal fissure on anterior inferior, oblique fissure on posterior superior part. Similarly, the right middle lobe, the lower half of right hemithorax, and on lateral view exactly depicts the location. We need 2 radiographs for exact location of the pathology: horizontal fissure on superior and oblique fissure on the posterior inferior aspect. Similarly, the right lower lobe, almost 2/3 of the right hemithorax, but the lateral view comes for our rescue with position on the posterior to the oblique fissure. Similarly, the left upper lobe comprises almost whole of the left hemithorax, but lateral view again helps us because it is located anterior to the oblique fissure, and lower lobe almost 2/3 of the lower half of the lung, lower half of hemithorax, and the location is on the posterior to the oblique fissure. Again, for the convenience of location of the pathology, sometimes the lungs are divided in zones, and we mostly interpret according to the zones. We divide the lungs into 3 zones with 2 arbitrary lines. The first line, superior, inferior, the first line passes through inferior border of the right the second rib anteriorly, be it on right or left. The second line runs through an inferior margin of the 4th rib on anterior aspect. The area of the lung between these 2 lines is mid zone. The line above this line below the clavicle is the upper zone, and line below the second line is the lower zone. Now, finally, after localizing the region of the lung, let's go into the findings. So, what are the findings? We have to interpret either from outward in or inward out. If we are going from outward towards inside, then first we have to evaluate the soft tissues, whether there are any symmetry of the soft tissue, any air in the soft tissue region for subcutaneous emphysema. After the evaluation of soft tissue, presence or absence of breast shadow in case of mastectomy patient, then any lytic or sclerotic lesions in the ribs or in the thoracic cage, any part of the thoracic cage, calcified densities, we have to evaluate it. After going through bony soft tissue, then the mediastinum, the structures in the mediastinum includes trachea, aortic arch, the pulmonary arteries and veins, and finally the heart. So when evaluating the mediastinum, we have to seek for the location of the trachea, then cardiomegaly, mediastinal and the hilar contours, as well as densities and deformities. Again, so now coming to the hilum, is as we know that hilum constitute the major airways like bronchi and pulmonary vessels, veins and arteries. The hilum should be always symmetric. Position may differ because of the position of the pulmonary arteries, the size of the arteries to rule out any arterial hypertension. Usually the left hilum is higher in position compared to the right because of the position of the pulmonary arteries. The hilar size, there should be always concave lateral borders. The size should be similar on both sides, and density also should be similar. This is the normal frontal radiograph of bilateral hilum. Normal lateral radiograph, position of the right pulmonary artery, anteroinferiorly, and the left pulmonary artery posterior superiorly. We do not find any density in the inferior part of the hilum, so it is always called half donut. But when there are pathology in the hilum, the lower part of the hilum gets extra densities, and we give it the name complete donut. So again, now finally the diaphragm, pleura, position of the diaphragm, the costophrenic recesses, cardiophrenic recesses, and then position of the hilum. Sometimes the right is always hilar or equal. Both hilum may be but both diaphragms may be equal in 97% of the cases. Left hilum may be higher in 3% of the cases. In inspiration, the position of the ribs, anteriorly 6th, posteriorly 10th ribs. Then see for any pathology obscuring the diaphragmatic outlines like pleural effusions, assessing the pleural and spaces. Sometimes there may be thickening of the pleura, fluid, air and pleural calcifications in case of pathology. Whatever is visible in the lung parenchyma, it is because of the visible vessel markings. We have to always observe from the lung fields from apices downwards, and we should always compare both sides at the same time. Sometimes in the frontal view, we may see the minor fissure. So the pulmonary vessels, positions and diameter, and the number of the vessels, usually in first intercostal spaces, 3 vessels. Then in erect position, usually the lower vessels are prominent. The vascular markings should be visible only in inner 2/3 of the lungs. It should not be visible outside. Otherwise, it is the pulmonary congestion or sometimes in the plethora. Because of the superimposition of many structures, there are sometimes we tend to miss findings while interpreting the radiographs. That's why they are called hidden areas, which comprises the bilateral apices, then the hilar structures because of the superimposition of the densities, then whole of the bony structures, the mediastinum, the retrocardiac region, as well as the infradiaphragmatic region, that is the posterior sulcus areas. So an example, there looks like a subtle increase in density in the right subdiaphragmatic region, the posterior sulcal area. When the patient was subjected for CT scan, we can see the mass lesion in the right posterior aspect of the right lower lobe. Now, before interpreting the chest radiographs, there are some signs, common signs. I have tried to incorporate most of it. If I have omitted, I am very sorry. So these signs usually helps us either in localizing the pathology or sometimes arriving at a differential or definite diagnosis. That's why these signs are applied. The first and foremost is the silhouette sign. Because lung contains different densities, we are able to see the borders of the heart, aorta, chest wall and diaphragm very well because of the air in the lung and the surrounding soft tissues. When there is loss of density differences of these lung and soft tissue, then there is loss of silhouette. It is called silhouette sign. If the borders are normally retained, either they are not adjacent to each other or there are because of the different radiographic densities. Now let's see it. So using structures and silhouette, the upper right heart border is adjacent to the upper lobe of the lung anterior segment. So any pathology is in that area, this border will be obscured. Similarly, the right heart border, medial segment of right middle lobe, aortic knob, apical segment of the upper lobe, upper left heart border, anterior segment upper lobe, lower heart border, lingular segment, the anterior hemidiaphragm, they are adjacent to the anterior lower lobe. So any pathology in these areas, these outlines will be obscured, and we call it loss of silhouettes. So let's see, there is a pathology in left mid and lower zones obscuring the left heart border. The lateral radiograph came out a rescue and shows the pathology in the left lingular segment of left upper lobe. Similarly, there is a right paracardiac heterogeneous soft tissue density with retained right cardiac border, meaning it is not in the medial segment of middle lobe, and lateral radiograph showed it in the lower lobe location. The next common sign is air bronchogram. Because of the similar densities in the distal airways and the alveoli, we are not able to separate them. But when the air in the alveoli gets displaced by the fluid or exudates, then we see the distal airways, we give the name air bronchogram, which is common. The causes can be from infective, sometimes edema, and neoplasm also. There are many causes for air bronchogram. So here we see the typical air bronchogram, heterogeneous soft tissue density with branching pattern of the airways. This is air bronchogram. Similarly, air bronchogram on right side also. The hilum convergence sign helps us in locating the mediastinal mass, whether it is anterior or posterior. If we are able to see the hilar vessels, it is either in the anterior mediastinum or posterior mediastinum, not in the hilum. Similarly, any mass in the hilar region, if it converges towards the hilar vessels, it is vascular origin. If it is not if it converges towards the heart, then it is non-vascular origin. This is applied for vascular versus non-vascular mass. Then donor sign, I already said, because of there is enlargement of the subcarinal lymph nodes and hilar lymph nodes, we see a complete donut sign because of the lymphadenopathy adjacent to bronchus medius. The cervicothoracic sign and abdominothoracic sign. If we see any mass having the border passing through the clavicle, that means it is either it is located in posterior mediastinum or in the paravertebral region, but not anterior part of the lung, to differentiate between anterior versus posterior. Similarly, any mass extending from thoracic up to the abdominal region, it is also in the posterior part of the lung, because the posterior sulcar area extends behind, even below the diaphragm also. Now, the spinnaker cell sign, when we are able to see the lobes of the thymus in case of pneumomediastinum, we are able to define it. When there is a mass adjacent to a fissure, then if with subsequent collapse of the lung, we get this golden S sign, the proximal convexity because of the mass, distal concavity because of the displacement of the fissure, usually seen in bronchogenic carcinoma in adults adjacent to the right upper lobe bronchus. Then when this left facial sign is when there is collapse of the left upper lobe, the lower lobe is hyperinflated and tries to cover the area occupied by the upper lobe. So veil-like opacity, given the name left facial sign, hyperinflated lower lobe. In case of collapse of left lower lobe, there is a very flat density seen in the paravertebral location, given the name flat west sign. Then juxtaphrenic peak sign, we see sometimes the peaks in the hemidiaphragm because of the traction in the inferior accessory fissure, major fissure, or pulmonary ligaments. We get this juxtaphrenic peak sign. In case of endobronchial or intraluminal pathology of the major bronchi, sometimes we are not able to see the distal part of the bronchi. We give the bronchus cutoff sign, suggesting intraluminal pathology, usually in adult because of the tumors, and children sometimes because of the foreign bodies rather than tumors. Then open bronchus sign, patent bronchus and distal airways with adjacent pathology in the surrounding, usually in the adhesive alveolar atelectasis, implying that it is not intraluminal pathology which is causing the collapse of the lung. A crescent of air within intracavitary body, we give the name air crescent sign. We use this sign and mono sign sometimes interchangeably. The difference is that air crescent sign, the intracavitary body is not movable, and it is adherent sometimes in bronchogenic carcinoma, invasive bronchopulmonary invasive aspergilloma. When we change the position also, it doesn't change, whereas in monod sign, if you change the position of the patient, it changes the configuration of the intracavitary body also changes in position. This is the monod sign in immunocompetent host. whenever there is a pathology in the lung, sometimes it causes expansion of the volume of the lung, leading to bulging of the fissure, usually given the name bulging fissure sign, and seen mostly in Klebsiella pneumonia, sometimes in streptococcal pneumonia also. A typical characteristic of the bronchoceal, when the air in the dilated bronchi is replaced by the fluid within it, then it gives typical finger in glove sign, a characteristic of invasive bronchopulmonary aspergillosis. We are not able to see the medial part of the diaphragm because of the no density difference between the mediastinum and the abdomen. When you are able to see the continuous diaphragm sign, it is due to pneumoperitoneum, pneumopericardium, or pneumomediastinum. When the large colon gets superimposed between the dome of diaphragm and the hepatic shadow, sometimes it is mistaken for pneumoperitoneum. However, the Hostel folds helps us in differentiating it from the pneumoperitoneum, given the name Chilaiditi sign. Similarly, in pneumomediastinum, on left medial part of the left hemidiaphragm, we get the Neckluria V sign. This is formed by the para-aortic air as well as the air in the medial side of the left hemidiaphragm. When in case of trauma, in fractured bronchus, the lung gets suspended only by the vascular pedicle, given the name fallen lung sign, usually seen in trauma. In pulmonary embolism with lung infarctions, we see peripherally wedge-shaped opacities with apex dilating towards the hemithorax in the inner part of the lung. This is given the Hampton's Thumb sign, very characteristic of lung infarcts. A little bit about artificial intelligence in thoracic imaging, because now there is a lot of talk about artificial intelligence. Almost sometimes they are saying they are going to replace the radiologist. So the current application in radiographs is mostly in the chest radiograph, and they are now using it for low dose chest CT for screening of lung cancers and triaging the pulmonary embolism. These AI also assist in detecting the pulmonary nodules, pneumothorax, pleural effusion, and other abnormalities. At times, it has the level of accuracy as that of the radiologist in detection rate, sensitivity, and reducing reading times. There are at present 882 FDA cleared AI enabled medical devices. Among that, 76.1% is for radiology, and 27 are for chest radiographs and 17 for chest CT scans. So it is hoped that the next generation AI with large language models will be helpful for generating the text reports from images, explaining results to the patient, as well as detecting errors in the radiology report. I have taken this from the radiology article of 2025. But however, there are challenges in AI implementation because there are practical issues educating the radiologists and trainees. There is liability risk as well as bias and disparity. We have to have on-site performance evaluation. We have to integrate with the IT infrastructures. Post-deployment monitoring is also important, and there are also cybersecurity concerns, radiologist compliance. Even though we can train the radiologist, technical radiologist, and the radiographs. This is the last but one slide. So technical aspects, strength and limitations of the AI, and we still need training in traditional image interpretation evaluation by radiology, very, very critical. Otherwise, we will not be able to find errors of AI. Then liability risk, whether the radiologist or the manufacturer providing the AI, still the debate. And because it is a biased data sets and unequal distribution of the AI-enabled devices, there is health disparities in underserved population as well as low countries. Just one example, this is a radiograph of a 56-year-old male in which this opacity was overlooked by the radiologist, and when retrospectively the AI-enabled CAD was applied, it detected the opacity, and the follow-up after 3 years, the tumor grew in size, and pathology confirmed it as lung cancer. Sometimes it is helping us AI, but we should be also equally good in interpretation. Thank you, the organizers, for giving me this opportunity to present here. And thank you all for your patient hearing. Thank you.